Thank you, Jacob. I think the podium was actually made for his height, not mine. Okay. I think it's a very good initiative because when we were doing our training for IDCCM in the past, in 2010-11, we have to go all the way to Chennai or to Bangalore to attend such an interactive session like this. I'm so happy that INEOS and Dr. Jacob has taken up the initiative to conduct such a program here, and they're planning to do it every year. It's a very good initiative. I came here only because he called. So, okay, now the next 20 minutes it's going to be really boring because I'm going to talk about things which we are not doing. So in 5 years down the line, maybe whatever I'm going to talk, maybe the talk of the town, or might be in the dustbin. So we don't know. So we'll just go about see about all the new topics. I'm not going to talk anything of ARDS. We'll see what new is there in the pipeline which can be developed over time. So we have to look at 4 parts. There is an evolving definition always happening, and there's something new about heterogeneity. Pathophysiology usually doesn't change, but we get to know more deep into that. And depending on the newer understanding on pathophysiology, we will try to see whether any new drugs will act or not. You all know that ARDS actually got the attention to the world during the time of COVID. So from ARDS, the most used term was cards or COVID related ARDS. So everybody, even in my house, my grandmother used to talk about, remdesivir. So she used to talk about vitamin C. She used to talk about the anti-helminthic drug. So she used to ask me, oh, you didn't give this drug to that patient. If you had given that, he might have survived. So that was the kind of information about ARDS in the common public. So coming to definition, so there are around 12 definitions right from 1915 to 2024. But we focus mainly on this 6, of which our generation mainly uses the Berlin definition. So all that is one of the most standardized definition ever accepted in the world. So after that, whatever came was a modification of that. So in the present one, what we are using is a global definition of ARDS, where the components are the same. Only thing, in chest imaging, we included lung ultrasound. And in oxygenation, we started including non-intubated patients, where we started taking into consideration of patients on HF, high flow nasal cannula, or NIV. And instead of PaO2, we started using SaO2 or SpO2, sorry. Why? So now we will be thinking, why not doing an ABG is not a heavy task? Because whenever they make an international definition, it has to be applicable even in the most resource limited setting like in a sub-Saharan country. Okay, we shouldn't make fun of them because there are even parts of our country in the northeast where the access to ABG is very limited. So instead of PaO2, we are using SpO2. So that's it. So the global definition includes the high flow cannula, the SpO2 instead of PaO2, allowing lung ultrasound, and that's the one. And just think about the lung ultrasound, you can see about the A lines, you can use the B lines to grade the degree of lung involvement. Even looking at the hepatization of the lung, we know there is a consolidation there. Looking at the pleura, we can look at our abnormal thickening. All these things will again help us in diagnosing a lung involvement. So a lung ultrasound help in diagnosing, monitoring, even looking at the complications and phenotyping it. So we'll come about that. Now comes the new terms. So just you don't have to write anything. As I said, whatever I'm going to tell, just listen like a story. So maybe a few years down the line, most of these terms you won't even hear at all. But for all DRNB candidates, this is a short note. So this is a 5-mark question in your 10 mark of your question. How many DRNB candidates are there? Okay, for you, this is a short note. There are 4 heterogeneity in ARDS. One is called spatial, biological, functional, and temporal. So what they try to prove is the policy of one size fits all does not apply in ARDS. In the sense, coming to spatial heterogeneity, when a lung get infected, why only the right lung get infected, not the left? And why only the upper lobe is involved, not the lower lobe? It's the same lung. So, the same COVID for patient A, it will affect the right upper lobe. For patient B, it affects the right lower lobe or left lower lobe. So why does it affect? So there is some heterogeneity in that. Then coming to biological heterogeneity, a viral ARDS slightly different from a bacterial ARDS. So that will again different from a pancreatitis induced ARDS. After COVID, we all became so expert. We look at the X-ray and tell this is COVID. Then the family said, no, the rat and the PCR is negative. No, this is COVID. This is a typical presentation of COVID. So we all started becoming an expert in biological heterogeneity even without learning it. So that is one thing. Now coming to functional heterogeneity. An ARDS in a COPD patient will be different from an ARDS in an ILD patient, which will be different from ARDS in a healthy patient, which will be different from an ARDS in a normal patient. So there is a difference in the functional capacity of the patients. Now coming to temporal heterogeneity. Same disease, same age group, we give the same treatment. Certain group respond, certain group doesn't respond. Some group respond to proning, some group doesn't respond to proning. That again tells us that there is an temporal heterogeneity in ARDS. So why do we want to know about all these things? Because knowing about heterogeneity helps us in choosing certain criteria like targeting the ventilation strategies, because we know that a patient's right upper lobe is infected or affected, his left lower lobe is normal. So when we put PEEP, we should not over distend the alveoli in the normal lung. So that is one. Next, biomarker based therapies, which we will be discussing in detail later, because there are ARDS which are hypo-inflammatory and hyperinflammatory. So the treatment differs for both. Now coming to personalized approach. It helps. So once we know the lung mechanics, it will help us to decide whether how much of the lung is recruitable, will he respond to proning, or should we adjust the PEEP and see, or should we don't waste time and go directly to ECMO. Next, it also helps us in monitoring the patient. You ventilate the patient for a few days, take a repeated CT test, and find out what is happening, again helping us in tailoring the treatment. So these 4 are theoretical part, as I said, which doesn't have much of practical implication, but it's better for us to know. Coming to pathophysiology, this is something which we all know. And ARDS has 3 phases. Exudative phase, which happens in the first 7 days. Then coming to the proliferative phase, which may last up to 14 days. Then we have a fibrotic phase, which will happen after the 2nd week. Very simple. As a result, there will be alveolar edema, atelectasis, shunting, increased work of breathing. This is for an MD level, this will do. But for our level as an intensivist, I think we should go a little more ahead, because all our newly proposed therapeutic strategies are actually based on this pathogenesis. So the more we learn about the pathogenesis, the more therapies we get to use. So what happens in the systemic circulation in ARDS? There is activation of macrophage, monocyte, neutrophil, eosinophil. All these things will produce an innate immunity driven immunoinflammation. And there's acquired cells like the T cells, the complement activation, all these helps actually produce again an immunoinflammation in the systemic circulation. So when all these things get activated, something happens in the lung. So what happens in the lung? There is endothelial barrier dysfunction. There is decreased resolution of pulmonary edema leading to a leaky lung or wet lung. There is cellular dysfunction, at last leading to cell death. So this is in total. You don't have to break your head. All we need to know is in ARDS, there is a release of various cytokines which activate the neutrophil, macrophage, and alveolar cells, ultimately leading to apoptosis or cell death. So, to us, what does it mean? Severe cytokine storm, hyperinflammation, and severe hypoimmunoinflammation. So whatever happens inside the patient, we see outside as cytokine storm or hyperinflammation. Now, as I said, all this, even though all the researches are happening much before COVID, at the time of COVID, there was a pressure on the research teams to come up with, some treatment modality for COVID. So that's when they divided all the ARDS into two types, hypoinflammatory and hyperinflammatory. As the name suggests, the inflammatory markers will be low in one, high in none. Definitely, whenever the inflammatory markers are low, the organ dysfunctions will be less. There will be less amount of vasopressor. Definitely, the mortality is going to be low. So, among ARDS, 70% of the patients will be hypoinflammatory, which has a mortality of approximately 20%. So one of the marker which we use is an IL-6 as an independent number. It doesn't have any prognostic value, but when a doctor or a medical bystander from the medical background comes, we can tell, see, the IL-6 is so high, so the patient is in a hyperinflammatory phase. So there's a very high chances your patient's mortality is going to be as high as 45%. So we always say that our mortality of ARDS is between 20 to 40%. Now, knowing that helps us in predicting the outcome, in the sense patients with type A phenotype or hyperinflammatory they require high PEEP for recruitment, but high PEEP carries high mortality. So high inflammatory markers, high PEEP, high mortality. So indirectly we are actually contradicting our own statement because the phenotype of the patient changed. Now we cannot tell, now we should understand that we know that PEEP helps in ARDS, but in this subset of patients, if the patient's PEEP requirement keeps going up, and if you know that your inflammatory markers high, that means that's a bad sign. It's not that he's responding to PEEP. That gives us a clue that probably this patient lies in the second category where the outcome is going to be a little bad. And in type B phenotype of the second, which is hypoinflammatory, the oxygenation is fairly good, and you don't require very high PEEP, and even if you keep that high PEEP, the mortality almost it will kind of stable. So keeping all these things in mind, we will think what all are the newer treatment modalities which we have. When I read this, you don't have to worry much. When I read this for the first time, it actually went over my head. So even I expect the same from you also. So you don't have to panic about it. So we can divide the therapeutic strategies. I'm not going to talk about the routine management of ARDS. As I said, I'm talking only newer concepts which may not be valid maybe few years down the line, or which may be the talk of the talk by then. Supportive therapy, we know about corticosteroid, we know about neuromuscular blocker, ECMO, and ventilator strategy. But the newer concept in this is about one thing about is NIV, which is the helmet NIV. Okay, just like a modification of the mask, nothing big about it. But what is more interesting is the mechanical power. All this while we have been talking about low tidal volume, high peak, where or plateau pressure were involved in mortality benefit. Now slowly from plateau pressure we went to driving pressure. Now we have the newer concept is mechanical power. Listen to this class carefully because Dr. Jacob is having few MCQs in this. So you might be able to win some chocolates in that. The mechanical power refers to the amount of energy per unit time used by the respiratory system. So which is determined by the volume, pressure, flow and the respiratory rate. All these things are measured by the ventilator, which we can easily get the volume, the pressure, the flow which we set and the respiratory rate. It is a better marker of lung protective ventilation. As I said, maybe a few years down the line, we will be talking more about mechanical power than plateau pressure or driving pressure, because in all the studies, higher the mechanical power, the higher was the mortality. And whenever the mechanical power was more than 17 joules per minute, there was a steady increase in mortality. So there is an easy formula to calculate the mechanical power, which has driving pressure and the respiratory rate. Now coming to the cell therapy. So we were talking a lot about the mesenchymal cells, the neutrophil, the macrophage, all these things. So what they did, it was, we all knew that in ARDS the problems are at the immunological level or the molecular level with the macrophage, neutrophil, monocyte, T cell. So if we can do something to modify the action of these cells, probably we can try to find a cure for that. So one thing which was studied extensively is the mesenchymal stromal cell. These are actually found in our bone marrow. It's already also found in umbilical cord in newborn babies. So the most commonly studied are the mesenchymal stromal cells from the bone marrow. So it actually helps in the recovery of the alveolar epithelial cell. It activates the immune system. It helps in the recovery of macrophage. It suppresses the function. It helps in repairing the barrier function. It has anti-inflammatory and anti-apoptotic effect. So you don't have to break your head. All we need to know is it has anti-inflammatory effect. It helps in immunomodulation. It helps in the recovery of the respiratory cells, and it helps in regaining the barrier function, and it is anti-apoptotic. So the mesenchymal stromal cells have a lot of theoretical benefit. Now time has to prove whether it has any practical benefit over time. Now to date, many studies have been done and they have definitely found it has found to reduce inflammation, improve lung function, and which was indirectly measured by the increase in the lung volume and the compliance in the lungs. And the same like stromal cells, there are non-stem cell based therapies also. The alveolar type 2 cells, they took the alveolar cell from human and they regenerated in the lab. They injected the cell back into the trachea and they found that the regeneration was faster. So they have tried a lot of cells therapies like this. And the third most important thing, which was the EV. I think the EVs are the most talk of the town now. Even government is giving subsidies for EV. So even ARDS also a lot of subsidies and grants are given for studies on EV. EVs include extravesicular cells. Those could be derived from the mesenchymal cells or from other cells. So here you look at it, what EV does. Just look at the box. It has look at the function. It inhibits lung hemorrhage. It inhibits lung edema. It decreases the permeability. It promotes vascular repair. It also helps as act as anti-inflammatory cell and immunomodulatory. So EVs are again a newer concept in ARDS. Next is the plasma therapy. How many of you have heard about plasma therapy? Yeah. During COVID, for a short time, people have tried convalescent plasma therapy because when we were running out of choices, you know, we used whatever we got in our hand. So, but over time, even during the within first 6 months itself, they said it is good, but the negativity or the negative side of conversion plasma therapy was more than the positive side, so that was taken out of practice. But authorities are given the chance to try IVIG in patients. So a lot of researchers are going on IVIG. IVIG definitely works, but the side effects are comparatively more than the placebo group. So they couldn't recommend, still more studies are required. Now coming to the third therapy, which is targeted therapy. We saw a lot of cells which are responsible for producing inflammation in ARDS. So why not we target those cells specifically so that we get the advantage what we want, and also we can avoid the side effects of a general therapy like a conversion plasma therapy, which is a generalized approach. So targeted therapy, they used antibody drugs, gene therapies, and mRNAs. So in ARDS, the targeted cells are neutrophils, granulocyte cells, antibiotics. So lot of drugs have been tried. There's a drug called civelastat, which targets the neutrophil, thus reducing the inflammation. The imatinib, which is used in, it's an antimitotic, which helps in decreasing the vascular leakage. And the third is the most commonest thing which we use, clarithromycin. If you go to a pulmonologist, they have an allergy case, a post-viral rhinitis or post-viral cough, which doesn't respond to any of the antihistamine. They might recommend macrolide, clarithromycin, small, like 250 BD of clarithromycin as the last resort, because it definitely has an immunomodulatory effect. And definitely in COVID related ARDS, we had something called anakinra, which is an anti-cancer drug. Thymosin was also tried. All these things are actually targeted therapy, which definitely require a lot of research in future so that we can come up with a recommendation. Now, what do they recommend is actually a personalized therapy. As I said, in ARDS, what we are trying to tell is one size fits all doesn't apply in ARDS, because different patients have different presentation, different etiologies have different presentation, different kind of patients have different presentation. So personalized medicine approach should be used. For that, we need to use personalized medicine, personalized mechanical ventilation, and personalized organ dysfunction dependent therapies. So personalized medicine indicates what? So personalized medicine. So for a virus, for a particular virus, do we need to use something? Even among virus, COVID responds to certain antivirus, influenza, H1N1 responds to oseltamivir. S3N2 has no action on oseltamivir, no effect on oseltamivir. Okay, so all these things helps us in personalizing the medicine. Now, personalizing the mechanical ventilation, as I said earlier, previously we thought tidal volume was the one which helps, which determines the outcome, which helps us in, categorizing our ventilator strategies. Later, we came to know it was the driving pressure, which is more important, and driving pressure targeted lung protective ventilation are more useful in treating ARDS patients. So, personalized mechanical ventilation, and we cannot use the same strategy for different kind of ARDS patient. Basically, what I am trying to tell is we are still, I just came back where I literally started. All our knowledge about ARDS is still the same, but there are a lot of new areas where research can be done, and we should be open for all the newer. Then come the organ function dependent personalized strategy. So here there's something, a new concept came, esophageal pressure guided PEEP. So the main advantage is this pressure was used as a surrogate for even pulmonary pressure, which was again a surrogate for lung water content. So whenever the esophageal pressure is more, we know that we shouldn't keep more PEEP because the intrathoracic pressure is very high, and whenever the value changes, we know that we shouldn't give more fluid, or these are a kind of patients for whom the fluid levels are very high or they are having leaky lung. So all we need to know is organ function also helps in determining our mechanical ventilation strategy, thereby in treating ARDS patients. There are a lot of other therapies also have been tried in ARDS, like aspirin. Even metformin has been researched. Still all these researches are going on. So just to conclude, regarding all the therapeutic strategies, we have the personalized therapy, cell therapy, targeted therapy, and the supportive therapy. Where do we stay now? We are still in supportive therapy. We are still in the phase of neuromuscular blocker, optimizing my ventilator strategy, extracorporeal support, and corticosteroid. These are only 4 areas extensive researches are made, but lot of newer concepts are there, and these are the 2 review articles which came out in December 2024 and 2025. I'll be happy to share with it, and that's it. So as I said, it's a little boring topic, lot of newer terms, lot of newer concepts. So how much of this will be useful for us, we don't know. So probably time has to prove. Thank you. This is not new. So this is the old wine in new bottle. So you don't have to break your head in this. So all these things are we are going to discuss about topics and areas which you all already know. So this is like kind of revision class. So because it usually all our talks are 15 minutes, and we select certain areas, but since it's a class for DRNB candidates, we'll be diving little more into theory, so this should be helpful for your exams also. So straightforward theory, we'll be discussing on epidemiology, pathophysiology, clinical presentation, diagnostic strategies, and treatment. Epidemiology, that keep changing. So most of the data what we talk are from the US. So whichever country you take, one thing is for sure, as age goes up, the incidence of pulmonary embolism goes up. So that remains the same. So the incidence, so this is not going to be your MCQ, but the last one was my MCQ for my IDCCM exam. So the percentage of patients in our ICU at risk for pulmonary embolism, 75% of the patients in our ICU are at risk of pulmonary embolism. Pathophysiology, we all know the pulmonary emboli consists of fibrin and red blood cells. 80% of the pulmonary emboli develop as DVT of the lower limb, but 6% can arise even from upper limb. So whenever we think about PE, don't forget the upper limbs, because it can arise even from upper limbs. And we all know every thrombus formation, every part of your body need to have either of the 3 components which we call as the Virchow triad, which include abnormalities of the blood vessel wall, abnormalities in the blood flow, or abnormalities in the thickness of the blood or the constituents of the blood called viscosity. So in all the patients with PE, either one or more of these three components will be present for sure. Okay. Now we look at the modifiable factors. In this, one thing which is newly added is the long air travel, because post COVID, all of us started traveling a lot. So so previously in the past, most of the patients in my ICU, we did a small study. Just like we took a small data of the 12 pulmonary embolism which came to the ICU. 8 of them were due to long air travel. So most of them were elderly people who went to see their kids in the US and who came back. So that's one of very, very common cause nowadays. And then it has immobilization, obesity, malignancy, estrogen use, pregnancy. Then there is non-modifiable factors like age, thrombophilias like APLS, and family history of thromboembolism. So diving a little more into pathophysiology, one thing, smoking is not associated with a high rate of ET. This is an MCQ. So among the risk factors, smoking is going to be answered because that's not an answer. Now there is something called unprovoked PE. That means patient presenting to us without any modifiable, mainly the modifiable risk factors. So when such a patient comes, no travel, no malignancy or anything like that, or no postpartum pregnancy, always look for hypercoagulable state like APLA syndrome, very commonest one, SLE, occult malignancy. These are the two conditions we need to look at patients who suddenly come with PE. Now, how do they present? So they can be asymptomatic to hemodynamic collapse, or 14% of the patients who had unknown cause of death on postmortem, they found a clot in the lung. So again, so 14% of the patients who had unknown cause of death could be having PE. So we know about PE that a clot goes inside the pulmonary artery, it obstructs the blood flow. So naturally it has to produce hypoxia. But even though hypoxia happens, the most worrying hemodynamic problem is the the most worrying pathological problem is the hemodynamic compromise. Because the RV is not able to pump blood into the LV. So as a result, over time, the RV gets strained. The RV goes into failure. Now the LV is not getting enough blood. So the coronaries are not going to get perfused. So by default LV is also going to go into failure. So now the degree of hemodynamic compromise depends on the size of the occlusion, the size of the clot, and the presence of pre-existing right or left heart failure. A big clot in a normal heart, patient may tolerate for quite some time. But a small clot in a already right heart failure or in a COPD patient who are already having a RV failure, they might not tolerate for a longer period of time. So the size of the clot and the pre-existing condition decides the clinical manifestation. Symptoms could be non-specific. So most of the times it is chest pain and dyspnea. They are present with 80% of the time. 10% they present as syncope. The signs are very non-specific: tachycardia, hemoptysis, and clinical signs of deep vein thrombosis. Now we will come to the evaluation part. So we'll go into, now whenever you hear the topic of pulmonary embolism, what comes to your mind? for the exam going people. Scoring system. So there are two areas which is very famous for scoring system. One is pulmonary embolism. Second is pancreatitis. So for exam purpose, so frankly speaking, none of us use any of the scoring. We study for the exam and just forget it. So you also don't have any other choice. You need to study. You need to study for the exam, and after the exam you can forget, because most of us are living in an era where whatever score you want to see is already available in your smartphone in a touch of your finger. So for exam purpose, we need to go in a systematic score-wise approach. So there are a lot of scoring system, and P stands for number 6, because everything is a multiply of 6 in pulmonary embolism. So we'll see about that. Step 1. For a patient present for whom you are suspecting PE, you're only suspecting PE. First step, assess a PERC criteria. PERC stands for pulmonary embolism rule out criteria. This has 6 components. Okay, 1, 2, 3, 4, 5, and the 6th one is any of those. If the score is 0, that means it is negative. If the score is 1 or above, that's positive. It's very easy. Of the 6, if any one is present, that means you have to go to the next step. If none of this is present, then you can actually stop there. So, okay, for our patients, it's +1. So we need to go to the second step. Second step is, okay, this patient has a possibility of having PE. Now, what is the possibility or what is the probability? Is it low, moderate, or high? For this, again, we can use scoring system. Two well-known scores are actually, one is the Well score and the second one is the revised Geneva score. The Well score again has 6 components. If the scoring is less than or equal to 4.5, it is low. 4.5 to 5 to 6, it is moderate. More than 6, it is high. Same way, coming to the second one, which is instead of Wales, you can even use revised Geneva. Again, it has 6 components. If the score is less than 4, it is low. 5 to 10, it is intermediate. More than 10, it is high. So it's very easy. Less than 15, 15 to 40, more than 40. Even in both. If you look, in both it is the same. Okay. Now if the probability is, the probability is very low, we know that probably we can actually, no, we cannot tell there is no P. If there is low or intermediate, probably we can do some blood test to confirm our diagnosis. If it is high, it's very easy, because if the probability is very high, we directly go to CT pulmonary angiogram, which is a confirmatory test. But CTPA comes with its own drawbacks. One, we need to shift a relatively unstable or a proper unstable patient down for CT, which is not an easy task. Second, organ dysfunction. If the patient, all these patients, because of hemodynamic compromise, they might be having a altered renal function. We may have to give contrast, which can again worsen. So little reluctant about CTPA. So we thought probably, okay, for low or intermediate probability, why not you do some blood test? So one of the blood tests which was studied was the D dimer. So we thought, okay, if the D dimer is negative and the probability is low, we will exclude P. If the D dimer is positive, we will go to the confirmatory test, which is CTPA. Now, what is the problem with D dimer? D dimer is very non-specific. So D dimer gets elevated in almost all the ICU patients. Not HD, all the ICU patients, the D dimer is going to be elevated. So, do we have a cutoff number? Yeah. So many studies have said probably you can use a cutoff number of 500. Okay. So in low or intermediate patients, a cutoff of 500 is good enough. But as I said earlier, a D-dimer of 500 is almost there in almost all the patients in ICU. So why not we slightly raise the threshold of D-dimers so that we can be more specific towards pulmonary embolism. Then came the adjust PE trial. So the adjust PE trial said if we can use a higher cutoff for D-dimer, we can actually rule out or we can reduce the use of CTPA by 23%. So the cutoff can be increased. So how to increase it? So in which all patient you need to use a higher cutoff. For that, we have that condition and your colleague feels it is not PE and you feel it is PE. In those scenario, you can actually, if any of this is present, use a higher number. If none of this is present, use a lower number. That's it. So the years definition, with all these things we hardly use this because in our practice, most of us directly go to CTPA because we don't want to take a chance. But for exam purpose, we need to use a stepwise approach. So this is what I said about the 1000 nanograms per ml. So be careful because this is the unit which is from the US based studies are using. So mostly in exam purpose these numbers might come. So few of the hospitals uses a different unit. But make sure, so my hospital, you instead of 1000 nanogram they uses 1 milligram or 1 microgram. Okay, so the numbers will keep changing. So now you got an idea how we graduated. Now, if the D-dimer is present or positive or more than 1000, or if the patient has high probability, we need to go and do a CT imaging. So the investigation of choice is always CT pulmonary angiogram because it has high diagnostic performance. At the same time, you can find out alternative diagnosis also, like a pulmonary, like a pneumonia, SARNs, or even pleural effusion. Few tests which are used in the past but now not used much. One is the VQ scan. During my time of examination, this was like kind of the investigation of choice, but now it's hardly used because it is less less readily available than CTPA. It takes a lot of time and it takes lot of manpower and it has relatively low sensitivity and it does not give us any clue about the alternative diagnosis. Now comes the most commonest thing which we do, the bedside echocardiogram. See, the bedside echocardiogram detect non-specific signs of PE, like a right ventricular dilatation. So where else can you get a right ventricular dilatation? Commonest one, pulmonary. The COPD patient coming to us, you have RV dilatation. We won't be able to know whether it is due to cor pulmonale per se or due to PE. And the second sign is the flattened what we call as a D-shaped ventricle. So the left ventricle looks like a D. So the negative predictive value of echocardiogram is only 50%. So that is the reason why echocardiogram is not actually included in the diagrammatic presentation. So in unstable patients for whom you really suspect PE and you want to decide whether to shift them down, the patient is too unstable to shift, should we take a chance and take the patient down? then you can do an echo and decide and tell that, see, this patient has high probability, and patient is sick, but the chances of him having a PE is very high, so it's worth taking the chance and shifting the patient down, because the chances of him having a PE is very high, so there is a treatment modality in our hands. Now, Doppler sonography, where do we use? This is mainly used in pregnant patients. In pregnant patients, you suspect PE, you do Doppler. If there is DVT, then your diagnosis of PE is almost confirmed. You don't have to do CTPA to confirm you can actually thrombolyze the patient, because again the die. Okay, so this is the recommendation. So detection of DVT obviates the need for other test for thromboembolism. Now coming, so whatever I said, we are just going to summarize it. So the first step is 1A is to look at PERC criteria. So PERC has how many components? 6. If the score is 0, then the PE is ruled out. Over. The story ends there. If the score is 1 or more, then we have to go for the next step, which which differentiate the patients into low, intermediate or high probability. What all scoring system we uses? Wells or revised Geneva. How many components in both? 6. So that's it. All we are done almost. So if the probability is very high, then very easy, straight away we shift the patient for CTPA. If the probability is low or intermediate, then we can actually use as the D-dimer test. Again, when using the D-dimer test, we can actually look at the scoring system. If the probability is low, we can use a smaller target. If the probability is high, we can use a higher target. So if again the D-dimer is positive, again we need to go for chest imaging, which is a CTPA, to confirm our diagnosis. So far clear? Good. Coming to the treatment part. Again, so to decide our treatment part, we need to decide how severe is the pulmonary embolism. For that, again, we have a criteria called pulmonary embolism severity index. Don't worry, again, this has 6 components. So P is the rule of 6. So age above 80, medical history of cancer, medical history of cardiopulmonary disease, high heart rate, low blood pressure, low saturation. These 6 components keep in our mind, so that we can tailor our treatment. So if the scoring system, so again this is very easy, like our PERC. If it is 0, that means very low in hospital, or that means patient doesn't have any of the severity index. That means this patient is absolutely safe. You can actually treat this patient OP wise using oral anticoagulants. Very clear, no doubt. Now all 6 criteria are present, or patient is hemodynamically unstable. So if the patient is hemodynamically unstable, that means we are directly into the last criteria, which is the high risk of in-hospital mortality. So hemodynamic unstable is indicated by a systolic BP less than 90 or a mean BP less than 65. The definition is the same what we use in cardiogenic shock. Basically, the patient is in what shock? Obstructive shock. The patient is in obstructive shock, so that's the reason. So hemodynamic unstable patient also is there, and the third component is the in between patient, where we need to decide, whether to thrombolyze or not. So if the severity score is 1 or more, but the patient is hemodynamically stable. So the score, so they are at the intermediate. So they comes into the criteria of intermediate risk. Again, we divide them into low and high. Now, how do we categorize? So, how did we diagnose low risk? Using low risk. We are again going back because we need to take to reverse gear and again come back. Only then we'll be able to revise that. Yeah. So, if the pulmonary embolism severity index is less than 1 or 0, that is low risk. If the patient is unstable, then it becomes high risk. If the score is 1 or more but stable, then it is intermediate risk. Even in the intermediate category, we look at them. We look at the echo. The echo shows RV dysfunction, D-shaped ventricle, and you send biomarker like troponins and BNP. All these things are elevated. That means this patient is intermediate high risk. This means this patient has a potential for worsening and becoming high risk. So this patient require HDU admission. Okay. Now, intermediate low risk, that means your severity score is 1 or more, but the patient is stable, but your echo is not showing any signs of D-shaped ventricle or RV dysfunction, then probably you can admit them. They need hospital admission, but not ICU, HDU. Then the last category, which we are all very clear, the high risk patient comes to ICU. So again, going back to where we started, no scoring system, 0, low risk, OP treatment using directly act or oral anticoagulants. High risk patients, very easy, they get admitted to ICU and we thrombolize. Now, intermediate risk patients, we do an echo, we send cardiac markers. If the echo is showing signs of RV failure or dysfunction and the markers are high, then we categorize them as intermediate high risk and we admit them in HDU or any high dependency unit. But if there is no RV dysfunction and we admit them in the ward. A ward patient, again, we can initiate them on oral anticoagulant. But the patient who got admitted to HDU, we have to initiate heparin therapy and within 72 hours bridge them over to oral anticoagulants. So the management is very easy. Low risk, OP-wise admission, oral anticoagulant. Intermediate risk, admitting in the room, again oral anticoagulant. Intermediately high risk, getting admitted to HDU, start them on heparin and gradually over 72 hours bridge them to direct oral anticoagulant. Last part is hemodynamically unstable patient, directly going to ICU and thrombolysis. And then we have our vitamin K antagonists are the oral, the warfarin dicumarol derivatives. Then we have oral anticoagulants like dabigatran, rivaroxaban, apixaban, which is very commonly used. So when you compare the conventional vitamin K antagonist and heparin, when you compare heparin and vitamin K and antagonist and directly acting oral anticoagulant, the use of directly acting anticoagulant, which are dabigatran, apixaban and rivaroxaban, the risk of bleeding was less. At the same time, the risk of recurrence was the same. So, whenever possible, use directly acting oral anticoagulants instead of vitamin K antagonists. So, our HDU patients require heparin. So, among heparin, the preferred one is always the low molecular weight heparin, because actually easy to administer and no low lab monitoring, require the risk of bleeding is less. The second option is unfractionated heparin. It also has its own advantage. It's very cheap. So the dose is like 80 units per kg bolus and 18 units per kg per hour infusion. If you're using heparin infusion, use an APTT to keep it between 1.5 to 2. Check your APTT very thoroughly. The advantage of heparin is, yeah, in case of a bleeding, you can actually stop it and reverse it with proton. So, and as I said, every patient in ICU, so we look at only two categories: patients who got thrombolyzed and patients in ICU. Patients in ICU, we started them on heparin and slowly we changed over to oral anticoagulants. How long should we continue this oral anticoagulant? We don't have a specific answer, but what is recommended is 3 to 6 months are good enough. But in patients with high risk like thrombophilia, cancer, etc., probably you may have to consider prolonged period of anticoagulation. And whenever you are considering anticoagulation for more than 6 months, better to prefer directly acting oral anticoagulant. So these are special population. Patients who have cancer diagnosed with PE, directly acting oral anticoagulants are preferred. Patients found to have PE incidentally during chest imaging should receive treatment just like a patient who has symptomatic PE, depending on the criteria which we discussed. So they need treatment. Patient asymptomatic doesn't mean they can go home. Patients with thrombophilia syndrome like APLA, they need to have lifelong anticoagulation therapy. As I discussed earlier, whenever you want to use anticoagulant more than 6 months, we use directly acting oral anticoagulant. In pregnant patients, it's always safer to use low molecular weight heparin because it does not process the placenta. Coming to hemodynamically unstable patient, we all know that the option is to admit them in the ICU and thrombolyze with tenecteplase, urokinase, septokinase, because there is definitely an absolute 30-day mortality reduction with thrombolysis. But before doing thrombolysis, we need to look at the contraindication, which we need to classify them as absolute and relative contraindication. If there is absolute contraindication, definitely we are not going to have an option of thrombolysis. We need to consider all alternative things which we will discuss. But if there is a relative contraindication, you have to weigh the risk and benefit and consider. As I said, hemodynamically unstable patient who cannot be thrombolyzed. If you have access to interventional radiology, definitely you can consider direct catheter related aspiration of the mechanical thrombus, or even we can consider surgical embolectomy. Again, a patient with a huge clot in the IVC or the renal vein for whom you cannot thrombolyze, malignancy, platelet count is less than 20,000, patient has a high chance of developing PE. Then you can consider IVC filter. But keep in mind, routine placement of IVC IVC placement does not carry any mortality benefit. Okay, so that's it. So that's the reason routinely we don't use. In patients who has a very high chance of the clot getting dislodged, but you can't start them on any oral anticoagulant, you can consider IVC filter. A small note about ICU related part of PE, the management of RV failure, right ventricular failure and pulmonary embolism. So whenever they present as obstructive shock. So noradrenaline is the first drug of choice in the shock. Vasopressin is the next therapy. If the blood pressures are reasonably good enough, you can consider an inodilator to prevent pulmonary artery RV coupling. Okay, so if you're not very confident, just leave it. It itself is a big topic to discuss. We are not going into depth of that. Now, fluid. So, in the absence of RV dilatation or RV dysfunction, you can give judicious fluid monitoring the clinical status of the patient. If you feel the patient is full, then consider loop diuretic, but be very careful regarding the ventricular function in these patients. Coming to respiratory management, even if the patient is not hypoxic, supplemental oxygen can be administered. It will definitely benefit because of the lung mechanics which happens in pulmonary embolism. But suppose if you have to ventilate this patient, be very careful about the effect of mechanical ventilation in right ventricular function. If our patient, because our patient is having right ventricular dysfunction, the moment you give a more PEEP than what is required. So what is more, we don't know. What is normal for patient A will be more for patient B. So if that is the case, again the RV preload is going to decrease and the RV output is going to further decrease. Again LV preload is going to decrease and patient is going into failure. So be very careful when you titrate the PEEP, and you decided to intubate the patient. Be very careful when you choose your drugs during intubation, because there are very high chance that patient might go into shock, or if the patient is already in shock, he might go into a cardiac arrest during the time of intubation. So use drug very judiciously, which has minimal negative inotropic effect. And as much as possible, avoid hypotension during intubation. So probably if the BP is on a borderline, you can actually start them on small dose of noradrenaline and then start the intubation process. In refractory case, you can use actually ECMO. ECMO can be used a bridge to intervention. The place where I got trained in Australia, every patient who get catheter-based thrombus aspiration for PE, they put the patient in temporary ECMO. Patient be fully conscious awake. They put the patient on ECMO. In the cath lab itself, they put the patient on ECMO, do the good thrombus aspiration. They finish off the procedure. They decannulate, then shift the patient to HDU. They don't come to our ICU. They just go to HDU. Keep in mind, ECMO can be used even in the absence of mechanical ventilation. You don't have to think that the patient is not yet ventilated, so you don't have to use ECMO. So ECMO can be considered even if the patient is not intubated. So these are the two good articles which had been taken and it can be studied. I think that's it. Thank you. So pulmonary embolism is more or less straightforward. It should be a revision for all of you. One was a heavy topic. There are a lot of questions because to ask also we need to have from there. The second one was too simple. I think they know more than us. Most of them are theory. So P is about scoring system. The rules just for the exams you have to by heart it, after the exam you can even forget it.
Thank you very much.
Just about the flow chart, when it is hemodynamically unstable and we see an echo finding of
No, hemodynamically unstable, no echo. Hemodynamically unstable, so thrombolysis. Over. Very simple. Hemodynamically unstable thrombolysis. Patient with scoring system more than 1, but hemodynamically stable. So they can, then we are finding out the kind of patient who can worsen over time. So when you give oral medication, it will take some time. So patients who can worsen, probably we can use a faster acting drug like an heparin based regimen, and we can slowly bridge over to oral anticoagulant.
So in intermediate high risk, can we thrombolyze?
It's not recommended because unless it is patient is not hemodynamically. See, imagine you thrombolyze and your patient developed a bleed. How are you going to justify it?
So the question that you asked is, can you thrombolyze? You can do many things. Okay. The question is, should you thrombolyze?
Yeah, but trials actually.
No. So the trials that have shown thrombolysis in hemodynamically unstable patients. The one was the Pedro trial. Okay, and they showed that in elderly patients you had an increased ICH. The second trial that showed probably there was a benefit, I forgot the name of the trial, but again that they used almost half dose of the antiplase and they gave the antiplase as an infusion over 6 hours. Okay, and that's a select group of patients in the randomized control trial. It's not coming to the guidelines. So example experience for the purpose of exam we cannot thrombolyze.
Very simple. So hemodynamically unstable, thrombolyze. Hemodynamically stable, the score is if there are signs of RB dysfunction, heparin based therapy and bridge over to oral anticoagulants. So we will keep our therapy is very simple for us. Okay. Thank you.
As a token of appreciation.
Thank you very much.
Next, I would like to invite Dr. Mathew. That's the head of the department of Medical College. He's going to talk about new modes of mechanical ventilation.
All right. What are the classical pressure control, body control, pressure support, all right? KSMA and CPAP. Okay. So basically these are the older modes that we used to use. So yeah. So that's how you can see here old team started with the polio acute. Started with the polio epidemic in Europe, where ventilators were used. Before that, there was iron lungs, which was a negative pressure kind of ventilators that were used. During the polio epidemic, the first positive pressure ventilators came into being. The first one was the M-Strong. So that's a volume controlled positive pressure ventilation. That was in around 1951. From there, newer ones have come. Time cycle volume control in Drager, and PEEP was introduced in around 2067. And Siemens Servo, which is the first electronic. That is when the whole thing changed from mechanical valves to electrical valves or electrical control, servo control machines, which can change or start making changes in the um, pressures and the volumes as the patient wants it. So it's that's where the major first electronic ventilator started around 1971, and then the newer thing came, pressure support kind of around 85, and yeah, so these are the older ventilators. But the problem, we know the conventional modes. We know the conventional modes of ventilators. They're popular, well used, understood. But sometimes they fail to match the patient's requirement. Patient might require more from the ventilator, and what you said might not actually match what the patient wants. So newer modes of ventilators were developed. Because the patient requirement and your ventilator settings don't match, one of the major problems that you get is asynchronous. Right. So these newer modes are made to reduce the asynchrony, promote better oxygenation if that is possible, hopefully faster weaning from the ventilator, and to be easier to use. So the goals were to avoid lung injury, keep the patient comfortable, and to wean the patient from the mechanical ventilation as soon as possible. So this was the idea of making newer modes of ventilator. But you have to understand to understand newer modes, you have to understand the terminology of ventilators. The classical terminology that we all use is the mechanical breath, or how the mechanical breath is described. And these are the three variables that are important: the trigger variable, the limit, and the cycling variable. You understand the ventilator actually only controls the inspiration, not the expiration. Expiration is passive. So the ventilator can control the inspiration. So trigger is when the ventilator is triggered. I think that's basic. Limit is what controls the thing. Usually it is either pressure or flow, correct? Either flow or pressure. And then there is a cycling variable which lets the ventilator end the inspiration. So that's all that we normally think about. But then there is always something called a breath sequence also, which is continuous mandatory ventilator. All right, when either the triggering or the cycling is controlled by the ventilator, it's called continuous mandatory. So the trigger or the cycling should be controlled by the ventilator. All right. Intermittent mandatory ventilation is, of course, sometimes when it is mandatory and sometimes when it is the other end. Here it is spontaneous. All right. So spontaneous means basically the triggering is by the patient and the cycling is also by the patient. That's it. So how can cycling be by the patient? When it is flow cycle. Okay. When you are flow cycling, so if it's time cycle or volume cycle, it's all controlled by the ventilator. If it is flow cycle, it can be controlled by the patient and not by the ventilator. Okay, why? How does flow get cycled? You're planning around 25% of your peak inspiratory flow. The moment you start expiring, what happened to your pressure inside the chest? It will go up. Right? What happened to the flow? Flow will? How does the flow come? In a pressure control or a pressure support, when the ventilator triggers, the pressure suddenly goes up in the inspiratory limit. The pressure inside the chest is low at the peak, say 5. And then you suddenly put 15 pressure support. So pressure inside the ventilator goes to 50. And the pressure inside the chest is 5. So the air goes from the ventilator to the patient. That's how it goes. Right? It will be the maximum in the beginning when the pressure is 15 and 5. And as the lung gets filled, the pressure inside the lung goes up. And after some time, the pressure is equal. And there's no flow. So we are told the ventilator when the flow becomes less than 25% to cycle. So how can we cycle it? When we try to expel, we are increasing the pressure inside the chest. You are expiring, right? The moment the pressure inside the chest rises, the flow will start coming down. We are told the ventilator to cycle. That's it. Okay, so flow cycle is basically controlled by the patient. So if you have flow cycled and patient triggered, that is called a spontaneous. All right, clear? All right. Now, that's not the only thing that we have there. Okay. So now you understand why people call it mandatory ventilation, spontaneous ventilation. Yeah, SIME has both, right? And type of control, you can have, generally it is the set point in most of the classical ventilators, like pressure is set, or the volume is set, or the flow is set. Okay, so you set a point where the how the ventilator will give the air. Okay, so the targeting mechanism is by the set point. But there are newer modes which have other things like servo, adaptive, and optimal kind of control. We'll come to that. All right. This is adapted from Chadburn classification. If you are interested in looking at it, look at it after your exams. All right. So the classical volume pressure controls are called open loops. That means there is no feedback from the patient. You set a target and the ventilator delivers that. Now, newer modes target to make alternation. When there is alternation in the lung, the target for the newer mode can change. So that is what is the difference from the older modes to the newer. And they take feedback from patients. And then it makes a feedback and makes it a closed loop feedback. All right. So the control cycle and the limit variables undergo self-adjustment. Okay. For your normal this thing, you have fixed everything, right? What is your trigger, your limit, your cycling variable? It's all you are setting it. Many of these variables can change in a newer mode. Okay. So these variables are no longer limited to a single parameter, but if threshold of common, so that also can happen. The variable that you are set to change, like say pressure control, your cycling variable is always time, right? And in pressure support, it's always flow. Okay, but something like an ASV, sometimes it is time and sometimes it is flow. So the mode itself can start changing from a control kind of breath to a support kind of breath. So depending on what the patient wants, the type of parameter that you keep itself can change. So these are the things that you can do in a newer mode. So these are the differences from the older mode to newer mode. Basically, all that you have said can keep changing according to what the patient wants or according to the mode that you have set. All right. So we'll come to that in a bit. If that becomes a little bit confusing, we'll come to that. All right. So there's another problem with the newer modes. One is called names of the modes. All right. The problem is each mode, when they find out, some company will patent it. The other guys will come with the same mode with a different name. So the whole thing is so complicated. I mean, there is one mode, but the same thing is called by like 10 names by 10 companies. Okay, so you get totally confused at what is going on. So please understand which mode that you are putting. Okay, so easiest way is to find out which is the trigger, which is the limit, and which is the cycling variable that you are setting if I am putting this mode. Okay, at least you'll understand what what you're trying to do. Okay, otherwise things can go totally wrong. Okay, so this is this is thing. Even volume control. See, look at different names, different companies. Okay, that's Drager, that's Hamilton, Servoi, that's Mathew, and PV. So all of them have different names or different or the same mode. All right. Uh, so pressure assist control ventilation, that is pressure control ventilation or whatever. So different names for everything. So please understand the same thing might have different names. Okay, or the same concept will have different names. Just wanted to put it across so that you'll understand. You know, don't worry about the names too much. Please understand what the mode is and you got it. Okay. All right. So aim of this thing now is to understand this dual control ventilation. All right. The dual control is till now all the if you have one, it's all single control, the single set point. Now we have two set points which will change things. All right. Now you can have dual control within one single breath. Okay. Normally pressure control is always pressure control, but then suddenly pressure control goes from pressure control to volume control in one breath. So that's dual control in one breath. Dual control in subsequent breaths or changes in the thing. So those are pressure limited flow cycle ventilation or volume support or pressure limited time cycle ventilation. We'll come to that. Which is generally PRVC, pressure regulated volume control or APC or adaptive pressure control, whichever one. Then there are other newer closed loop ventilation mode. Adaptive support ventilation, you would have heard of adaptive support. And proportional assist ventilation called TAV. These use algorithms to change your support from the ventilator. And then there are bi-level modes. Basically, it is kind of like CPAP at two levels. CPAP, giving CPAP at two levels. Okay, so that's simpler, easier to understand. And then neurally adjusted ventilation, which is NAVA, and high frequency oscillatory ventilation. I'm not going to say that because generally we don't use it nowadays. All right. So dual control ventilator can be, first is dual control within the single breath. This is volume assured pressure support or VAPS. Okay. Not a very good mode to use, so don't use it. Just kept this on for you to understand. Okay. All right. So it's a modification of pressure control. Volume, basically it's a pressure control mode, but you give a target to the ventilator, and in the pressure support mode, if the ventilator is not achieving that target, it will change over to volume control and give that extra volume till the whole volume is over, and then only it starts as a pressure control. All right, and the ventilator will see whether you are given a time whether the whole tidal volume is achieved or not. You set a tidal volume. If the tidal volume is not achieved, a certain flow will be kept. That's how volume control works. You know, so flow will be given till that volume is achieved, and then only it will cycle. If the if the tidal volume is achieved before that, then it will cycle at that time. All right. So it's a volume cycled ventilation, pressure control. So, but then the limit is 2. It can either be pressure limited or flow limited. Okay, and it is in one single breath. Each single breath, it will look. So, if you put 400 tidal volume, the ventilator will deliver 400 tidal volume. Okay, right. So, this is volume assured pressure support. So, whatever you adjust the pressure limit, respiratory rate, peak flow rate, peak FiO2, trigger sensitivity, and the minimal tidal volumes that you want to achieve. So, if you doesn't achieve the tidal volume, it will change. So, this is how it goes. When you start, it is more like a pressure control. It's like a pressure control. So, pressure support levels is flat, like pressure control, and your flow is decelerating, like in a pressure control. If you attain the tidal volume, then it goes to cycle. Okay, to cycle. Right. If you don't attain, then look, oh sorry, then it'll change because the pressure will go from pressure. I think the battery is not very good. Okay. Battery. Light. Okay, let's see. So, okay, if the tidal volume is not met, you can see the flow time graph starts as a decelerating, and then if the tidal volume is not met, then it goes to flow. A certain flow is delivered till that tidal volume. The problem in this, you get a very long inspiratory time. Usually, patients will not tolerate that kind of inspiratory time. And usually there is a lot of asynchrony. Exactly. So the whole idea of covering asynchrony actually worsens asynchrony. So not a great mode to use. So that's why I said, okay, you understand this mode, but please don't use this. Okay. Many of your ventilators sometimes have this. Don't use it. At least that is something that you can do. Okay. All right. Okay. So you can see, trigger is either the machine and patient. So patient can trigger. Limit is pressure and flow. Okay, both will come. Either pressure, but if tidal volume is not achieved, then change to flow. And cycling is volume. So you have given up so much volume. So once the volume is attained, the ventilator cycles down. Breath sequence is usually mandatory. Okay. And you say control point is set point, not dual, it's set point by volume. Okay. So you get better when you compare this thing with pressure control. Maybe you have a better tidal volume. Increase inspiratory time if the flow is low, and there will be higher heat peaks. So unfortunately, problem is it's not very good for synchrony. So you go to dual control ventilation, dual control in subsequent. Okay, these are much more interesting ones. So this is called adaptive pressure control, or more commonly known as pressure regulated volume control. So this is adaptive. You have understood that. Okay, the thing is the ventilator adapts itself. All right. So unfortunately, so many names, as you can see. Pressure regulated volume control is from Mathew. Volume control plus is what they say it in Pulicken Bennett. Auto flow in Dagger. And Dagger is very funny because you can put pressure control or volume control or whatever, and then put auto flow, and it goes to this. Okay, so you don't know volume control you put, and it will probably be giving PRVC. Okay. So if you are not sure, it can go like that. Adaptive pressure ventilation is what Galileo people say, or the Hamilton people. So as you can see, it's all the same mode. All right. Now, what is this? Adaptive pressure control, or PRVC. It's a pressure control ventilation. This is also pressure controlled. Okay. And the tidal volume depends on the lung. In a pressure control, the tidal volume depends on the compliance. Okay, fine. And the patient's effort. So if the tidal volume, the compliance comes down, tidal volume comes down. If the patient takes a bigger effort, the tidal volume will go up in a pressure control ventilation, right? Okay, fine. So if you put a patient on this APC mode, or adaptive pressure control, or PRVC mode, as you are more familiarly known, okay, the inspiratory pressure is adjusted to get a minimal tidal volume. So here also you're putting a tidal volume for the patient. The ventilator will, and then the other thing that you keep is the tidal volume increases, machine decreases the inspiratory pressure, and vice versa. Okay, so that's what it does. Basically, when you set pressure control ventilation, you look at the, you set a pressure, look at the tidal volume, and then go up and down as needed, right? This up and down business, the ventilator does by itself. You don't have to be there. Ventilator will increase the pressure support or decrease the pressure support to get the tidal volume that you have set. Minimum tidal volume that you have set. You can go more than that, but minimum. Okay. So, okay, this is adaptive pressure. As you can see, okay. So, what happens here is, this is, if the patient is not breathing, this is diaphragmatic pull. Okay, you can see in this breath, patient is not breathing at all. So the ventilator is giving that much pressure, and the volume is set. If the patient is breathing more, ventilator will reduce the amount of pressure, but the tidal volume will remain constant. So in a normal patient, if the patient breathes more, tidal volume will start going up in a pressure control ventilation. Adaptive pressure control or PRVC, when the patient starts breathing more, ventilator will give. All right. So usually what happens is, he'll give one breath and see. The pressure is more, next breath it will reduce the pressure support. All right. If it's too low, it will, next breath it will increase the pressure support. And then, so breath by breath, the pressure support can keep changing till the machine finds out what is the pressure the patient needs, and then you. All right, clear? Nice mode. Yeah, very useful. Yeah. All right. So trigger, machine or the patient. Limit is pressure only here. Cycle again, time cycle like pressure control. Mandatory breath definitely, but the control one is adaptive. The ventilator adapts the support or changes the support, unlike a pressure control ventilator. Okay, fine. So it promotes inspiratory flow synchrony. Okay, very good at synchronizing patient, and automatically reduce ventilatory support as the patient starts breathing more. The problem? Yeah, not ideal for patients who have an inappropriate increased respiratory drive. Patient is getting respiratory acidosis. The patient starts breathing more. Ventilator will start giving less. Patient will start breathing more again because, yeah, he wants more air, but the ventilator will start coming down. All right, and very soon patient won't get any breath from the ventilator, and he will have to respiratory failure. All right, so you have to be around and see what's going on. Otherwise, these newer wonderful modes can also mess up things. Okay, fine. Volume support is the pressure support version of the other one. Okay, PRVC. All right. So volume support, instead of the time controlled cycling, it's just the flow controlled cycling. That's all. Otherwise, it's nearly the same. The pressure keeps on changing. For the pressure support keeps on changing as you set a tidal volume, and to get the tidal volume, the pressure support keeps on changing. That's what we do. We do set a maximal pressure limit so that ventilator will not give more than that. Okay, even for PRVC we do that. So the trigger is patient, limit is pressure, cycle is flow, not time. Here the breath cycle is spontaneous because there's no machine timer here. It's only patient timer, and the cycle is also flow, so it's spontaneous. And the targeting scheme here is also adaptive. So that's the difference between a volume support and PRVC. All right, or adaptive pressure control. All right. Okay, so you got an idea of how the adaptive thing works, right? Okay, now some other new closed loop ventilations. Adaptive support ventilation. So everybody is interested in this one. Usually, I don't know why, but okay, it's an interesting one. So it's a form of mandatory minute ventilation, or it's a ASU delivers a pressure controlled breath using an adaptive or optimal scheme. So it's not exactly adaptive like the other one. Ventilator has a algorithm inside which will make what is the optimal this thing for the patient, and then optimal tidal volume as well as optimal respiratory rate. Okay, so how it does is it uses something called the Otis formula. Okay, the Otis formula is in 1950, before your parents were around, most of yours. At least it's an old formula which looks at the compliance, the resistance of the respiratory system, and find out which is the best respiratory rate and the best tidal volume to give the minimum amount of energy into the lung. Okay, so that, or the minimum energy that you need to expect. That is what it is calculating. So the machine or the idea is, we normally go to that minimal amount of energy that we need. We normally breathe at that level. Okay, so the ventilator is trained to go to that, find out that level and go to that. So you're using the Otis equation and then find out the minimum respiratory rate. Yeah, so it can reduce the energy, or the energy that is being given to the lung, which is a good thing that is coming up in a big way now, because now we think that the more energy you spend, the more lung injury also there can be. So that's something that is coming up in a big way. So yeah, so this is the very interesting mode, because it finds out the optimal level. All right. So basically, already I think I've gone through this, minimizing ventilatory work or breathing. So ventilator calculates the required minute volume based on the patient's ideal weight, sex, and estimated dead space volume. And the clinician sets a target. So you can go from 100% or more than 100%. So normally when the patient is sick, when you are sick, we need to have increased tidal volume. In your ARDS, COPD, whatever, you take more. Okay. So usually when you are intubating and you start the patient, you start with somewhere around 125%, and then you come down. Okay. When you're weaning, you come down to 80, 70, 40, around 25, you can just probably take him off the ventilator. Okay, so basically that's the whole idea. So the tidal volume is calculated by the normal ventilation divided by the optimal frequency, and it is implemented. All right, let's see. I'll just show you how it's done. So this is something that, this is the Otis curve. Okay, so with each respiratory rate, what is the tidal volume needed is calculated. You look at the minute volume and then it calculates the tidal volume and the respiratory rate, and it is the minimum or minimum energy which is found, and that's the green dot there. And the ventilator will try. So for this patient, it's around 16 breaths and around 400 tidal volume. So if the patient is paralyzed, that's what the ventilator will do. It will give 16 breaths and 400 tidal volume and that tidal volume. The good thing is, it's a very, yeah, that is when the patient is paralyzed. So what happens when the patient is not paralyzed? So you give pressure control breath, 16 breath, and it's like something like an adaptive pressure control, the one we do. So it goes from adaptive pressure control, 16 breaths, and it will give that 400 times. Okay, 430 watt. Okay, so you'll go to that. All right. Now, the moment the patient starts breathing, what happens? The ventilator cannot keep the respiratory rate constant anymore. So it will only try to keep the tidal volume. For this patient, I keep the tidal volume. But patient is breathing now. Minimum 16 will give, but if the patient is breathing more than that, it will go to kind of a volume support. So the volume support will try to guarantee that 434. Okay, but the ventilator cannot set the respiratory. So that's what it is. And it automatically goes from pressure, yeah, something like a ERVC to volume support automatically. Okay. So yeah, it's a very highly flexible mode of ventilation. Should ventilate majority of patients most of the time. Yeah, good. But then there is some problem. Some difficult ventilate patients, severe asthma, severe ARDS. bronchospasm, any leaks anywhere, especially this bronchospasm, because it's looking at the air coming out, look at the tidal volume. Tidal volume will go everywhere, there is a leak. So if you have a leak, then this might not work very well. Another problem with this ventilation is if you do not reduce the pressure support or the minute ventilation that we need. Okay. At one point, patient will be very comfortable. So the ventilator is given the optimal breath. Patient don't have to breathe. Patient will just sit there, holding control. All right. So the minute you see the patient is comfortable and patient is not breathing, it's the time when you have to adjust the ventilation down so that the patient will start. So if you miss that, patient will get stuck there and you will not be in there. Okay, so that's something that can happen with this or this method. Okay, to prevent all that, these guys have come up with something new, okay, called interleavent ASV. All right, they added an ETCO2 and a saturation probe to the machine. So the machine itself will start coming down on the minute volume and PEEP and FIOT. All right, so yeah, so it's becoming even more automated now. So this is how the ASV adaptive support ventilator works. There's no separate method. It will work like a pressure control. And if there is more separate method, ventilator will work like a pressure. Either yeah, it will go into volume support. From pressure control, it will go to volume support. Okay, and it will keep the tidal volume same. And you can wean patient from volume support. That's the whole idea. Okay. So the ventilator settings in ASV that you have to add is the patient's height and sex. This is to calculate the ideal body weight. So that ventilator can calculate the minute volume. Percentage of normal predicted minute volume, that is your goal of ventilation, and FiO2 and PEEP. These are the only things that you have to do. And the newer mode called intervent ASV, all you have to do is put this thing, patient's height and sex. Even this is calculated by the ventilator. So you basically don't have to do anything much. All right. So automatically ventilator will reduce the thing. Okay. I've tried this. Ventilator doesn't automatically reduce as much as we would. So it takes more. So, but okay, if you don't have many very good people in the ICU, it might be a useful way. So it is intended as a sole mode of ventilation. Offers automatic selection of ventilator setting, automatic adaptation to changes, less human manipulation, better synchrony, and automatic weaning is also there for, especially when you change over to interleavent ASV. Okay. So that's a good thing about ASV. The proportional assist ventilation is called PAV, or proportional pressure support in. This is in Hamilton. Oh, sorry, it is in PB. PB ventilators have PAV or PAV plus they call it, and proportional pressure support is there in Dagger. Yeah, same thing. Okay. Ventilator assist in proportion to the patient's instantaneous effort. So it's something. The greater the effort, the greater the support. In like volume support and volume control, pressure regulated volume control, what happens if you pull more, the ventilator will give you less. All right. In this one, if you pull more, the ventilator will give you more. Exactly opposite to what volume support does. It's something like volume support, but opposite. All right. It looks like your work of breathing, and if you are working more, it will give you more. All right. And if you're not breathing as much, it comes down. All right. So it's something similar to a power steering on a car. Okay. You don't have to work as much to turn. So you do not have to work as much to get the adequate flow or the support support that. You don't have to pull that much. Ventilator will. All right. So the patient can ultimately control the magnitude of breath and the timing and the breathing pattern. Okay, it's a support mode. So it's flow cycle, and there is no preset pressure, flow, or volume goals, but safety limits are there. Okay. Now, how does it do? At the first couple of breaths, it checks the respiratory system character, look at the resistant, the compliance, and it also look at the patient effort. Okay, it measures the effort through the airflow actually. Okay, because looking at the once ventilator knows the compliance and resistance of the ventilator, this thing, looking at the flow, you can figure out patient's work of breathing. And once it gets a work of breathing, a percentage of that you have to set 10%, 100%, whatever it is, the ventilator will give extra. All right, if you give 100%, the work of breathing is so much, the ventilator also give double that, totally double. So ventilator also will give that much. So more air will basically come. So as you can see there, when the patient effort is more, the pressure support actually goes up, increases. In the other side, it was when the patient pressure goes, the pressure support comes down. Here it goes up. Okay, so yeah. So here the metabolic acidosis patient will be okay, because if he starts breathing, ventilator will give. All right. So the settings in PAV are airway take, which is whether it's an ET tube or a tracheostomy, the inner diameter of the tube, the size of the tube, the percentage of work supported can be somewhere from 25 to 95 or 100. Tidal volume limit, pressure limit, and expiratory sensitivity. That's all you put. It does reduce the work of breathing. There is improved synchrony, definitely. Adapts to changing in changes in patient's lung mechanical effort. Decrease the, again, you don't have to go up and down and change the pressure support. Patients breathe less, the ventilator will automatically come down. All right. And it does decrease the need for sedation. Unfortunately, if there is patients having respiratory depression due to any cause, or we're going to go and sedate that patient, ventilator will think patient is not breathing and will give less and less. All right. Unlike where you have in ERVC, where it will give more and more. Then, okay, here it will be the other way around. Or if there is large air leaks, again, bronchofloral fistula. If the air is not coming back, ventilator will get confused. It's also patients with severe hyperinflation like severe COPD or asthma, or high ventilation drives also, you have to be a little careful, because if you put high support and the patient starts breathing more, too much support can be given, large tidal volumes can be given, and sometimes auto triggers can also be happening in these patients, because too much ventilator chest movement happens, and the ventilator can go into something called run time. And the last, not the least, the bi-level ventilator mode. For that, you need to know the CPAP. I think everybody knows CPAP. It just gives a pressure support. Patient can breathe on their own, on top of. So that's the pressure level, and the patient breathes. Inspiration, it goes up. Okay, the flow goes up, the pressure actually comes down here. Normally, in every ventilator, when the patient inspires, the pressure goes up. Right? That's positive pressure. In CPAP, the pressure goes down. Okay, and the patient breathes out, the pressure goes up. That's what happened normally in our body. But we just do that pressure support. Right? Now, what the bi-level ventilators or APRV or bi-level ventilators do is adjust the CPAP. It goes from 5 CPAP level to 15. 5, 15. It keeps on changing. All right, at a particular rate, you can adjust the rate, and the time it stays on top. All right. So basically, it's something like a pressure control. Okay. If you put say 20 times a minute, 20 times a minute, 20 times it goes up, and 1 second it stays up, and then it comes down. So the patient is paralyzed. It is something like a pressure control. All right. Generally like a pressure control. And the difference is during inspiration, patient can expire or inspire, and even during expiration, patient can inspire or expire in this particular mode. That's the only difference. The patient can breathe in or out even during high pressure or low. So if you paralyze the patient in that, something like pressure control, but patient can. Okay, so that's the whole idea. So okay, again the names, as you can see, different names for this. APRV and bi-level. What is the difference? Yeah, time. If you have inverse ratio of bi-level, it is called airway pressure release. All right. Otherwise, it's called bi-level. So your expiratory time is smaller than your inspiratory time. So then it becomes airway pressure release ventilation. If your inspiratory time is smaller than your expiratory time, which is what we normally use, you call it as bi-vent or bi-level or whatever, bi-pap or whatever. Okay, that you want. So these modes you deliver pressure control, time cycle, and time triggered and time cycle breaths. Just like pressure control basically. Ventilator maintains a constant pressure even in the face of spontaneous breaths. So patient can breathe in and out at that level. So how do we set the mode? We keep T high and P low. Then you have to have a T high and T low. How long you have to keep. And one can add pressure support or a automatic tube compensation to assist ventilation. So newer modes have, on this you have pressure support. So if you breathe, you get a support on top of this. Okay, so that was also coming up. So APRV generally have very short, not just inverse ratio, very short T low. Okay, so ratio will be 4:1 or less than 4:1. So you normally never set a pressure control in that kind of, but you can do that for ARV because patient can breathe out during inspiration, right? So in the biphasic model, ratio between 1:1 to 1:4 or even lesser than that also can be done. So these are the two modes. Airway pressure release ventilation, you can see inspiration, when the patient is paralyzed. Okay, there is no breath. But once the patient starts breathing, you can see patient breathing during, yeah, there can be inspiration and expiration during the higher level also. Okay, so patient can breathe in, or even during expiration, patient is breathing in and out. Okay, so you can do that. Okay, so as you can see, the difference is the expiratory time is very short in airway pressure release ventilation and long in biphasic ventilation. Okay. So APRV is a lot of people swear by APRV in ARDS. When I paralyzed the patient, I got like pressure control. I don't know. If the patient is not paralyzed, maybe milder ones, maybe it will be good, but I don't know. I have not tried it much. That's why I did try it in one of my severe patients. Maybe that was the wrong thing. Maybe I should have started with the less severe ARDS patient and see whether it's beneficial or not. Okay. So when it's very severe and we paralyze it, it's pressure control. Biphasic was intended for weaning, but again, studies does not show any support for these newer modes for weaning. And then the last and not the least, NAVA utilizes diaphragmatic EMG signal to trigger, govern, flow, cycle and cycle the ventilator. So what it does is you have the diaphragm, they put in a wire into the diaphragm and that will measure the my electrical signal from the diaphragm, basically like your ECG, but your diaphragm. So when the diaphragm is activated, when you try to breathe, your diaphragm gets activated. So if you want a bigger breath, more electricity is produced because it is contracting more. If you want a smaller breath, less electricity is produced. So when the electricity is produced, that means you are breathing. So that triggers the machine, right? Ventilator will know how much energy electricity is produced. That means if you want to breathe more, you are producing more electricity. According to that, ventilator will increase the pressure or decrease the pressure support. If you are decreasing less, then less support. All right. And the moment you stop breathing, the electricity disappears. So, cycling. So everything is depending on the, so the trigger, limit and cycling can be dependent on the electrical signals from the diaphragm. Got it? Not from your other. Okay. So that's what we do with this. So a sensor array that's it's in a catheter that's put in the esophagus. Synchronizes, gives the best synchronization because of all the modes, it's actually measuring your diaphragm and giving the breath as per your wish. So that's the best synchronization. And then it can give assistance according to the strength of your breath. So that's also very wonderful. So what you have to set is the gain. So you have electrical impedance. So on that, how much pressure you have to give, less or more, can be set on the gain of the this thing. That's what you have to basically set. So that's the electrical myograph, and then that's how the breathing pattern will go. As you said, the best synchrony, very wonderful. When wonderful mode, yes. Problem is cost. Exactly. That catheter will cost 25,000, and it lasts around 4 to 5 days, or maybe a little bit more. Okay. So well, that's why nobody uses Nava here. Otherwise, it would have been a good. So thank you.